Hello, welcome to video number 4 of the Antibiotics Primer series. This one's a focused look at vancomycin and azithromycin. These are two antibiotics which we're going to consider together, and they're not chemically related. They're not, despite what the names are, and despite the fact they end in mycin, you might be tempted to think they're similar, but they're not. They're quite different, and but we're going to consider them together because they allow you to target focus groups of bacteria. Little word of warning. Of course, when you're learning about antibiotics, there is value sometimes in learning the prefixes and suffixes of drug names. But here, the mycin part actually refers to the origin of these two drugs. They're both from a soil organism called Streptomyces, which is where their name comes from. So just keep that in mind when you're learning about antibiotics. So in the current videos, what we're looking at is a paediatric case, so a young child with a community-acquired pneumonia. They've previously been prescribed amoxicillin, and that's been escalated to ceftriaxone. So in the current video, what we're going to consider is the fact that 12 hours later, there's been no change. And you're now starting to think, do I need to further broaden the coverage to include other organisms, other agents that I've maybe not thought about yet? There's a decision point to be made. The decision is, do you wait and watch, or do you act and switch up and maybe add additional agents in? The reality is that you would probably wait. 12 hours isn't a huge amount of time. Antibiotics don't work instantaneously, unlike some of the other drugs you may well prescribe in the future. They take time to act, and many, such as things like amoxicillin, require time on target. They require time in contact with the bacteria in order to exert effects. So this seems like quite a short time, but just for the scenario, for the story we're presenting here, let's say we added another antibiotic. Just to reiterate, I introduced this idea in the amoxicillin video. Whenever you prescribe an antibiotic, there's always going to be not quite a perfect overlap between the infection, or the agents, or the infective agents that your drug kills or stops growing, and then all the other organisms that in this case are going to cause community-associated pneumonia, but whatever infection. And what you're doing is, when you're prescribing an antibiotic, is you're prescribing empirically, trying to get this overlap as big as possible. But here, with the child situation getting worse, maybe you're starting to think, well, actually, the antibiotic, or the bacteria causing the infection is actually over here in this blue sector. Looking at just a very, very quick look at some of the data, for lots of infections, there have been very, very rigorous studies which have looked at determining the exact precise causes of those infections, and these things have then fed into the guidelines. So when we talk about the first-line treatments, second-line treatments, typically these antibiotics are selected to kill or stop the bacteria growing that are the most likely cause, and this all derives from these laboratory data. This paper looks at causes of, or bacterial causes of, community-associated pneumonia in paediatric patients in the United Kingdom. And we see, just looking at the numbers, Streptococcus pneumoniae and group A strep as being the top two causes. And surprise, surprise, they're the two things which are covered both by amoxicillin and in ceftriaxone and a few other things. Ceftriaxone, of course, covers some of the gram-negatives which are here as well. So Haemophilus, Moraxella, Klebsiella. But there's a box that's a little bit missing so far in the story. Staph, we've covered a little bit of staph so far, but we might want to be thinking now about covering all of the staph. M. pneumoniae, that's Mycoplasma pneumoniae. Mycoplasma is significant because it falls into this group in the top right. We haven't even thought about this yet. None of the drugs we've prescribed so far covers atypicals. And MRSA is the version of staph which we haven't yet also thought of. They can both cause CAP, so we need to now start thinking about, do we need to add in antibiotics which can cover these things? And this is where azithromycin and vancomycin come in. Let's start with azithromycin. Azithromycin, when you're learning about it, when you're thinking about it, the key thing and what it really gives you is atypical cover. It is brilliant for atypicals. It works on bacteria that have no cell wall because it targets the ribosome. That's good. It also can target intracellular bacteria. And this is a really key learning point. Often people think that intracellular bacteria are basically untouchable by antibiotics. That's not true. They can still be treated. Azithromycin is a great example of this. So Legionella, Mycoplasma, Chlamydia, there are others as well that can be treated with azithromycin. It's not just all about the atypicals. You gain or you retain a little bit of streptococcus coverage as well. You lose staph cover, and there's no enterococcus cover. Now, that's enterococcus, again, we don't need to worry so much about for this particular story. For the gram-negatives, it's a bit more complicated. So azithromycin has a little bit of activity, but it's quite patchy. So with the gram-negatives, we're talking about lots of different strains of bacteria called the same thing, and it very much depends on the strain you're working with and dealing with. The reality is, if you had someone with a gram-negative infection, you probably wouldn't jump straight to azithromycin to treat. You would probably treat them with another antibiotic where you were more confident of success. But briefly, there is still a little bit of activity towards some of the respiratory gram-negatives. There's a really key gram-negative to think about with azithromycin, though, and that is Neisseria, specifically Neisseria gonorrhea. So you'll see azithromycin used in your gum clinic placements where patients will be treated with azithromycin, again, because Neisseria gonorrhea can form intracellular infections. So it's really effective at killing those bacteria. There's a third symbol that's appeared on the screen, and that's next to the endemic gram-negative rods. So it is sometimes effective against them. It's very much a maybe. Again, you probably wouldn't think azithromycin if you had a gram-negative rod infection. It doesn't work on Pseudomonas, nor does it work on anaerobes. So when you're thinking azithromycin, it's atypicals, and as a reminder, you would probably use azithromycin in combination with another drug. If you were thinking CAP and you were thinking this person doesn't seem to be responding, combination of azithromycin and another drug widens that spectrum out even more. And just on the screen here, you can see the 3 drugs we've spoken about so far, just all on one screen. And you can see how azithromycin now plugs a gap. The graph on the screen, the table on the screen shows Legionella. Of course, Legionella is one of those examples of the atypicals. Okay, so that's azithromycin. But going back to this table, so we've now done what we can for Mycoplasma pneumoniae. What about Staph aureus? Well, remember, specifically, Staph aureus can be split really into 2 groups: MSSA, methicillin-sensitive Staph aureus, and MRSA, methicillin-resistant Staph aureus. Sometimes MRSA is also just referred to as MRSA. It tends to be more of an American expression, but you do sometimes hear it used. We're going to use vancomycin here to treat the MRSA infection. The spectrum of activity with vancomycin is actually really easy to remember. Vancomycin is useless against everything except gram-positive bacteria. Atypicals, gram-negatives, if you're treating a patient with those infections, no matter how much vancomycin you put into that person, it will have no effect. Vancomycin works on the cell wall. The atypical bacteria may not have a cell wall. It's also a large molecule which physically can't get into the gram-negative. So it can't get to the cell wall because the gram-negatives protect it with an outer membrane. So therefore, we're talking about treating gram-positives. Unsurprisingly, it works on Staphylococcus. It works on both the MSSA and the MRSA. To reiterate, when you're prescribing vancomycin, what you're basically gaining is MRSA coverage. It's really important to say, particularly for patients who are being treated with vancomycin, unless it's, as we'll come on to in a second, unless it's a C. diff infection, when you're prescribing vancomycin, what you're basically saying is, I think there might be an MRSA infection going on here. For MSSA, you probably wouldn't use vancomycin. And the reason is that unless it's an MRSA infection, using vancomycin to treat staph is a bit overkill. What you actually want to try to do is switch to another antibiotic. So another group, which are sometimes referred to as anti-staph penicillins, that includes flucloxacillin, are probably better Flucloxacin doesn't work on MRSA, but it will work on MSSA. So thinking about the ladder, that's a good example of a de-escalation and good example of antibiotic stewardship. You're preserving the vancomycin for when you need to treat MRSA. It works on strep, it works on enterococcus. Now, again, looking at the screen, there's a gap missing, and that gap is the GI anaerobes. Remember, when we categorize bacteria, they can be categorized in a few different ways, but here the key ones are cell wall and respiration. Those two things are not mutually exclusive. What I mean by that is that you can be an anaerobic bacteria and be gram positive. You can be an anaerobic bacteria and be gram negative. Here, the bacteria on the screen, which I haven't really spoken about, is C. diff. That's a gram positive anaerobe, and indeed it can be treated with vancomycin. It's not the first line treatment. Currently, the first line treatment at the beginning of 2021 is metronidazole, but the second line is vancomycin. Vancomycin has another thing to say. So aside from you would need to review it quite carefully, you'd need to dose it quite carefully, but there's a third aspect to consider, and that is that it can't be absorbed orally. So that means if you take it orally, the drug stays within the GI tract. Now, actually, when you're treating someone with a C. diff infection, that's actually quite useful because you want the drug to stay entirely within the GI tract. If you had someone with a bloodstream MRSA infection and you gave them oral vancomycin, it wouldn't actually be that useful because the drug won't get to the site of infection. So going right the way back to video number 1, it's not enough just to say, does the drug kill the organism? Does it get to the site of infection? In this case, it's actually the route of administration would be wrong. You would need to give it intravenously to treat a systemic infection. So that's vancomycin. Let's add it to our chart. Again, vancomycin, you'll see on the screen, it's skewed to the left. It gives you coverage against gram positives. It's brilliant for gram positives, completely useless at everything else. So it's an easy one to think about in terms of its spectrum of activity. There's a few other drugs on the screen here as well. Drugs like teicoplanin, linezolid, daptomycin. These are similar spectrums of activity, and these are also similar because they have massive structures which physically can't get into the gram negatives. So we've gone through 2 antibiotics, azithromycin, brilliant for atypicals, vancomycin, brilliant for gram positives, particularly giving you MRSA coverage. That's video number 4. Thanks very much.